Our panel is called Perspectives, and what we have aimed to do is sort of gather from the tremendous wealth of experience in the room just one small possible cross-section of that experience to look at how diverse perspectives on the problem of access to affordable medicines and how we build a successful movement to challenge pharma industry power. The people on the panel have very different vocations and different orientations toward the issue, and we hope that we're going to learn from each other as we talk for the next hour, and everyone in the room will have that similar opportunity. And you should feel free as we get through an initial round of questions toward each other to ask questions of your own. So, brief introductions. Again, I'm Peter Maybarduk. I direct the Access to Medicines program at Public Citizen. People on this side of the room can't really see me. That's awkward. Hey, guys. Okay. We're a consumer advocacy organization with 45-year history working on the public interest before Congress, the federal agencies, and the courts. And the other panelists we have Laura Marston, is a relentless patient advocate for affordable insulin in the United States. Laura has lived with type 1 diabetes for 22 years since she was 14. She lives in Washington, D.C., and serves as Assistant General Counsel for an international video gaming company. We have Meg Jones-Monteiro, who's responsible for leadership of the Interfaith Center on Corporate Responsibility's shareholder engagement and advocacy on global and domestic health issues. She provides leadership expertise and strategic direction to help develop and implement coalition member shareholder engagement strategies with corporations. Her portfolio includes pharmaceutical, health insurance, food and beverage, and other sectors. We have Dr. John Powers, who practices in infectious disease and internal medicine at George Washington University School of Medicine here in Washington, D.C. He is on the National Physicians Alliance FDA Task Force. And we have Dr. Matthew Kavanagh, who is visiting professor of law and director of the Global Health Policy and Governance Initiative at Georgetown's O'Neill Institute for National and Global Health Law. Matt's a political scientist by training. His research and writing focus on the impact of human and constitutional rights on population health and on the political economy of health policy, particularly HIV and other infectious diseases in low and middle income countries. Those of us who've been working on the global access issues together have known Matt for a very long time for his relentless advocacy, especially in the global south. And we have Clifton Garman at the opposite end, who's a senior policy analyst at Vocal New York, where he monitors, examines, and promotes policies designed to improve the quality of life for marginalized communities while engaging and educating elected officials across the state through grassroots lobbying. Clifton's work is particularly focused on advocating for the health and well-being of people who use drugs and on hepatitis C elimination throughout New York State. So I'd like to start with getting some orientation on how we each work on access to medicines issues and what has brought us to dedicate ourselves to work on this. And I'd like to begin with Laura, I guess, just to hear a little bit of your own story as a patient advocate.
So, hey everybody, I'm Laura Marston. As Peter said, thanks for the great introduction. I was diagnosed with type 1 diabetes at 14. So for those of you who don't know, what that means is that I need a constant supply of external insulin put into my body at all times. We can't go any amount of time without insulin. I was diagnosed in 1996. It was also the same year that Humalog insulin came out. That's the same insulin I use today. I even brought a little show and tell for you guys. There it is. Not even the packaging has changed. I mean, this is 1996 insulin right here. I remember my mom, when I was 14, buying my first vial of Humalog, and we had insurance at the time, but Humalog wasn't covered under it. It had just been released that year, and it was $25 a vial. Fast forward to, I went to law school. As Peter said, I'm a lawyer. And one of the reasons I did that was thinking that I was protecting myself, realizing it was going to cost, a fair amount of money for me to stay alive. In 2012, I joined a small law firm, and unfortunately, the owner of the firm died. His estate closed the law firm down, and because it was before the Affordable Care Act, I was ineligible as a type 1 diabetic for health insurance on the private exchange. So for quite some amount of time, I had to pay list price. So I go to the pharmacy and I say, how much is this vial of Humalog? Thinking still use the same thing, thinking maybe it'll be $30. And they say $180, 2012. Since then, this has increased to list price $275. That's the price set by the manufacturer. If you were to actually go to CVS, Walgreens, or a pharmacy, they mark it up even more. So this that lasts me about 1 week, and that I cannot live without, now will cost you out of pocket about $350. That's a 1,200% increase with absolutely no change to the product. So since 2012, I've been fighting with the Insulin for All movement. There's a panel of many of us this afternoon who they'll be able to shed more light on the specifics of that, but fighting for affordable insulin, fighting for the list prices to be lowered, and ultimately fighting for federal regulation over the pricing of medications that people can't live without.
Thank you, Laura. Clifton, I was wondering if you'd be willing to hop in and talk a little bit about your experience of moving from patient experience to community organizing experience.
So I work for Vocal New York, and there's a few of us in the room. And Vocal New York is deeply rooted in harm reduction. We consider ourselves people that we believe in radical acceptance. And among everybody, among our members, among our base, among our opponents, radical acceptance. And we make no exceptions, which made it very difficult to book the ticket here because I had to accept that our operations director was too busy to do it. But it's deeply rooted in our organization, and it's deeply rooted in myself, and it's how I got to this work. And what Vocal is a organization full of people who live on the margins, people who advocate for their own healthcare and well-being, and people, although the odds are stacked against them, they live and they thrive and they fight for their rights. And so that's the kind of family on the margins that Vocal is, and that's the family that we're a part of. And it's kind of the world that we're trying to create, at least in New York State for now. So with that model, we try to take that statewide. We try to build statewide, well, we don't try, we succeed in building statewide power. And we do that by informing communities about the disparities that exist that they may not be aware of, about everyday health issues, particularly hepatitis C when it comes to the work that I'm doing, that they are impacted by, and the way that New York State does not prioritize their health care, and the way that government, just in general, healthcare is not the priority. We have to bring it to them. So advocates, activists, organizers, community leaders have really become the beating heart of what is compassion in this country. And we can't really depend on government to do that. So that's what we're doing in New York State. And we're not giving people power, we're empowering people, or helping people to feel empowered, reminding them of the power that they already possess, and then utilizing it to pass real legislation, to make real change in our state, and to demand price negotiations. So when it comes to drug prices, what we do around hepatitis C is not only inform our communities about this epidemic that we're experiencing in New York State at disproportionate proportions, but we are also encouraging people to bring that power to Albany, to our capital, to let their elected officials know and remind them why they were elected, holding them accountable, and we're bringing their constituents into the room. So if you're going to vote against a bill that's not prioritizing our health care, you're going to look us in the eye and you're going to tell us to our face that you're not going to pass our health care bills. So that's pretty much what we're doing with that. And then in addition to that power, we kind of utilize the rage that comes up when people find out about the unprecedented prices of hepatitis C treatment. which is coming down now, but at its peak was so high that it was setting all types of immoral precedents, and that the state was rationing this treatment for people, and people were dying. People were dying. 1,000, minimum 1,000 a year were dying in New York State. 15,000 new cases just 2 years ago in New York State. Well over 280,000 people living with hepatitis C in New York State. And if you want to learn more about hepatitis C, come to the panel. The session later today about it. So I'll leave some for imagination. But all of these things were happening, and what it would take is for our state to negotiate these prices. But again, we are the heartbeat. We are the compassion in the state. So we had to bring that fight to Albany, to the Capitol, so that they can prioritize our health care. So, yeah, I think that, yeah. Okay.
Thanks, Clifton. That was great. So, Dr. Powers, I was wondering if you could talk with us a little bit about the role of the medical profession. You know, of course, we're talking about a profession that at once has a great many people's faith in our lives in its hands, and yet has a complicated role with the pharmaceutical industry at times. How do you see it?
Sure. I guess when Peter and I were talking on the phone the other day, you asked me sort of how I came to this. And this issue of prices is not new at all. I mean, 30 years ago when I was an intern, I remember an attending physician told me to write a prescription. I did my internship in inner city Philadelphia, and we wrote a prescription for this child's ear infection. Ear infections get better even if you don't give them any antibiotics. But the mother left the clinic, came back about a half an hour later, crumbled the prescription up and threw it at me and said, "If you think I can afford that, you're out of your mind." That was 30 years ago. That prescription costs about $120. I look back on that now, that's like peanuts now, right, of what we're talking about today. And to think about that, you know, in terms of one of the questions you asked me was, you know, can physicians be a part of this, you know, helping to change this? You know, another way of looking at it is if you're not part of the solution, you're part of the problem. Right, so that physicians need to get involved. And believe me, I never thought I'd be sitting up here doing stuff like this when I was in medical school. But you feel a moral obligation that you have to do something about this. The other part of my job is I actually do clinical research too. Most people don't know that in my field in infectious diseases that most of the new antibiotics are approved by the Food and Drug Administration, which is my third hat I wore in my life as a regulator, working there for almost a decade, but that most new antibiotics are approved allowing those new drugs to be 10, 15, or 20% worse than what you could get already. And some research that we did actually showed that even though those drugs were no better, the last 8 antibiotics that have been approved all cost 10 times more than what you could get. So this seems to be an issue now that we're getting less and less evidence, and the drugs aren't as good, but we're being asked to pay more, which sounds to me like the ultimate in used car salesmanship. No insult to used car salesmen who might be in the audience. But are we really getting what we're paying for here? And then that gets me to my third way I came to this was at working at the U.S. Food and Drug Administration of, are we really prioritizing patients first? Or are we putting speed and getting a drug approved over what benefits patients? 2 nights ago, there was a county meeting in my neighborhood that they're putting up a bike path. And I jokingly said to the woman who was up doing this really nice presentation, it's going to beautify our neighborhood, but it's going to take 2 years to get these things through the approval process. And I said, oh, you should take it to the FDA. They'll approve it in 6 months. So it struck me that it's going to take longer to put a bike path in my neighborhood than to actually get the evidence that you would need to know whether is this really a drug or is it a poison. I always tell patients the only way I can know this is a drug is it's got more benefits than harms. How do I know that? From the clinical research that shows it. But if the drug is approved based on a change in a laboratory test and not really does it make a patient live longer or live better, then I don't know whether this stuff is actually worth paying for. And the last way I come to this is as a parent of 2 disabled children and as somebody who's had illnesses myself. And my wife and I always marvel, like, don't these drug company executives ever get sick? Like, doesn't anybody in their family ever get sick? Right? Wouldn't you want that kind of care to be given to your relatives just like we would, right? So, and in what I do, I always tell people, most of you hopefully will never ever take a cancer chemotherapy drug in your life. I guarantee you'll get an antibiotic before you die. Right? In fact, most people in this room probably had one already, right? But when you realize that the evidence for that these new antibiotics are actually benefiting you is actually slim to none, right? And that's not something you really know. And that brings me back to your original question. Most physicians don't know this kind of stuff, right? So communication here is something I think is very important. And when it comes to, I know, and what we're going to talk about in the pricing issue, this issue of transparency and how these things come to cost as much as they do is a really big issue. So that's my story of how I came to this point.
Thank you. So Meg, you engage with the investors in this industry. You engage with the companies. How do they see some of the issues that John is talking about? Is there room for movement? And at ICCR, how do you try to get the drug industry to change its practices?
So how many people here have ever heard of shareholder advocacy? Okay, so some people have. So just by way of a little bit of background, ICCR is a membership-based organization of around 300 institutional investors. So what we do, some of them are pension funds, faith-based investors, but really what our focus is changing corporate policy to benefit the larger community. It's a balance between these investors having fiduciary responsibility to their clients, right? They have to kind of look out for the interests of their clients, but at the same time, it's under this umbrella of a moral compass. I know the concept of a moral compass right now is kind of non-existent. But in the health space, we have investors who believe that access to healthcare is a right. And the way that they feel like they can achieve that is through engagement with companies. And so the way that it works is that we have the opportunity to talk with people, who are at the C-suite level or the board, or people who are making decisions, business decisions. And so one of the issues that we have been really concerned about is around drug pricing. So for quite some time, both on the global side is the access to medicines. So in places where you have, people living with a higher burden of disease and they clearly have no access to be able to pay for it, how are these companies broadening their access to the products that they're developing? And so we start with dialogues, and it really is asking for something very specific. And that's kind of why it's really exciting for me to be here, because we have investors who understand the investment space, but they don't necessarily understand the complexity of the healthcare system, particularly in the US. So getting partners and people to tell us, if you guys go in and have this dialogue with this company, this is what you should think about the ask being. So dialogues then sometimes lead to what we would call resolution filing. Now, the dialogues, ideally the company doesn't want to go to a resolution because the resolution becomes very public. We can say, if you don't do this, we will do this. And we can get media attention. It gets posted on what's called the SEC's website if a resolution goes through, the Securities and Exchange Commission. Analysts see it. The public sees it. So if there's something like particularly that they see as a risk to them, they don't want that there. So it's in their best interest to kind of have that dialogue with us, but oftentimes that doesn't happen. So we've actually filed resolutions with a number of companies on drug pricing transparency. And unfortunately, this was about 2 years ago, we didn't get it through the SEC. But we wanted them to disclose basically the methodology of how they set prices for their top 10 products. We didn't get it through, but we still continue to have conversations with the companies and have been a little bit more successful this year in getting resolutions through a different way. But I don't know if we're going to get into that later, but I think the biggest thing about shareholder advocacy is that oftentimes you hear companies say, well, we're beholden to our shareholders, right? It's just what they say. And our group of investors believe that it's about long-term value. So you need to be responsible to the community in which you're serving, but at the same time, as investors, we're not interested in like short-term profit. We're interested in how sustainable is your business going to be over time. And that means in order to understand that, you have to engage with stakeholders, be it investors, NGOs, basically the individuals and communities that are benefiting from the products that you're developing.
Thank you. So Matt, it sounds like some MEG dialogues with the investors, with companies. Hello. And so it sounds like there's both carrot and some stick applied. You've worked on a number of corporate campaigns. Might say if there's a stick over there, you bring the baseball bat. What's your perspective on running a campaign and holding these companies accountable?
Great question. So look, a couple of thoughts. So one is, in thinking about kind of how I came into this work, right? In part, Jen Flynn, I think yesterday told a story about the kind of creation of Health Gap, where I have worked and in part grown up, where the realities of looking our government in the face and realizing that part of what's happening is that the United States government is joining a lawsuit alongside the pharmaceutical industry against Nelson Mandela, right? Like literally the pharmaceutical industry thought it was a fine thing to put their names down to say the United States government and pharma versus Nelson Mandela. So, right, this is not a situation where it's likely that we can win with brilliant arguments, and if only we had better technical specifications, we would figure out exactly how to get pharmaceutical companies to agree with us. This is the lesson, I think, that we have learned over and over again as we think about how actually prices do fall. I remember one very specific story where I was sitting with an Indian colleague named Lungangti, who is just an amazing person living with HIV, leader in India, who for many years has been kind of fighting the power of corporations that have kept medicines out of the hands of folks in India. And one of the very first times I met him, I said, well, we have this really interesting new policy idea. And I kind of was like, don't you think this would be really interesting? And he kind of stopped me about halfway and said, stop. But what if the entire basis of what you're assuming, which is that we can't win, right, is wrong? Because you know that we keep winning, right? You know that tenofovir is available, right? And this is subsequently because Indian activists won. And I kind of said, well, you're right. Let's back up and ask. So I said, okay, like tell me a little bit more of some of the stories. And one of the ones that I love most is actually the story of how Indian activists actually won something called Section 3D, right? So Section 3D, and now I'm going to get really wonky, in part because I'm standing up here in front of something that says Georgetown law, right? But Section 3D is this section of Indian law that actually says we comply with the TRIPS agreement, but we reserve the right to actually decide within Indian law whether or not, how we will grant patents, what they will look like, what the basis of that will be, and we're going to give people the right to challenge those pieces, right? Well, that law came into being because a number of activists were literally sitting in a room at a moment having a meeting when all of a sudden the patent bill came up. And I think I saw Jamie Love walk in at some point. I think Jamie was actually in this meeting, right? And they literally, Anand Grover and a couple other people, along with the activists, literally got in a car and drove down and sat with a bunch of legislators and said, no, don't do what the United States government is suggesting. Don't do what the pharmaceutical industry is suggesting. Instead, here's some alternative language that they literally wrote on the spot, right? And because of that, when tenofovir, the kind of frontline HIV drug that kind of is used around the world now, right? That now costs, $50. The fact that when tenofovir then came up, they were able to challenge the patent on it. They were able to push the drug companies to make it more affordable. They were able to have it declared, have the patent not accepted. And they were able to build campaigns that actually meant not only did the pharmaceutical company, the originator company, bring down the price, but that a number of generic companies hopped in and entire governments supported the push to make it available, right? So those opportunities come up and are available, and we can be smart about them, but they don't come up just because we're around. So final thought just for me is one of the things, after working for a long time, I think I've been involved in corporate campaigns, I've been involved in government change campaigns. I think we could talk through kind of how we can do both of those. But one of the funny things that I did is then after many years in activism, ran away and got a PhD, and did it in political science. And in part because there is almost no evidence that actually the current system of intellectual property, et cetera, drives innovation. Just none. If you look at it, one of the lines that Pharma loves is development, that around the world, the reason why the whole world should embrace the current US standards is that it will drive better development, and yet there's zero evidence of that, right? So if there's no evidence, but it's still the law, and it's still what's actually getting traction all over the world, with governments all over the world, then what we actually need to look at is why. What are the actual political dynamics that are driving that, and how do we do it? And one of the things that we know is that there's zero evidence also that the corporations tend to just agree to reduce sky-high profits, right? That's also a thing that doesn't really happen, right? So that's fine. We just should not expect that. Instead, we have to think about what are the levers that can actually make corporations behave differently, and most of them are legal, right? And then what are the ways in which we can have government officials behave differently? Some of them are legal, but most of them are based in movements. So I think as we think about that, as we move forward, piecing those pieces together and assuming that actually we won't shift because the broad public agrees with us, but instead we will shift because we change the frame that this conversation is being had in, and we change the incentive structures of elected officials. That is likely to be the way in which all of a sudden corporations say, oh, now we're scared, we're worried, we will reduce prices. Because without that, without some government stepping in and saying, we're actually going to, we're gonna have a compulsory license, we're gonna have various things, there's zero evidence that actually prices will come down. So how do we find those answers?
Thank you, Matt. Dr. Kavanagh.
Some days.
So we're all here in this room because we want to be there at the beginning as we build an affordable medicines movement in the United States, first of its kind. This is where it begins. And these are some of the tools we have. We already bring in this room tremendous amount of experience from very different sectors, experiences with the healthcare system, with movements, with our own experiences in health, different professional skills and activism skills, and so on. We have some of those up here, many more in the room, and where I hope we can get over the course of the next 45 minutes or so, sort of the beginnings of what do we need from each other up here on the stage and in the room to make our work more effective and start consolidating this into a coherent movement that moves together and is very effective. So I'd invite people in the room to think about that and think about questions you might want to pose or ideas you might want to pose to the panel as we go. And I guess I would like to ask the panelists, what do you find the greatest challenges in your line of work to be? What is hard about your approach, and what would make it easier? What kind of support, expertise, mobilization, creative activism would sort of help you crack that nut, help you get to that next stage with your advocacy targets or people in the professional associations you're trying to influence. Would anyone, let's see, Meg, I think you had some follow-ups.
Challenges. It's really interesting to kind of be on the inside. I've worked in healthcare in a variety of different capacities before doing shareholder advocacy. And when you are sitting on these dialogues with companies, to hear them constantly, it's kind of like you have some people that are very receptive, some companies that are very receptive, and then you have others who aren't. And I think oftentimes it's reflective of leadership, right? Like what we're experiencing now. The leader at the top sort of sets the tone. But a challenge that we have is having enough data and information when they pivot. So oftentimes we'll ask questions and say, this is what, as investors, this is what we want to know. Oftentimes it's, all right, can you tell us more about sort of, we need more disclosure and transparency on your R&D costs. And we get sort of the same answer. So being really smart about how we can respond to those types of things and sort of hold them accountable for the way they're answering is something that we as investors, and that it's kind of my job to help them do that, but prepare them adequately to kind of give an answer back. So I think that's probably one of the major challenges we have. I think another one is that we do have a lot of people from the faith-based sector who have done a lot of direct sort of grassroots organizing as well. But stories, oftentimes if we can overlay what we're asking with like, this is the business angle, but this is like the personal angle. This is what's happening because of what you're doing as a business. So being able to bring in some of those patient stories and direct stories when we aren't, or our members aren't always sort of on the front lines hearing those stories is also something that's always helpful for us to sort of collect and share.
Do you see a relationship between, I mean, presumably in dialogue with investors, with companies, there's a good faith relationship that you are working to cultivate. How do you see the relationship of external advocacy playing into that? The sort of role of public clamor in helping the dialogue go in a direction that's more helpful.
We do have, so we haven't done it as much on the health side, but on the human rights, we work in human rights, food justice, water stewardship, and climate change, and then health, which I would argue everything's under human rights and health is all connected. But we actually do have the ability sometimes to get organizations or people on calls who aren't investors. Also, we have annual General Assembly meetings. So those are the meetings where, when I talked about the resolutions, they get on the proxies and then the shareholders can vote. And so we also do work with organizations to try to get people who are not investors into those meetings. But it is a balance because there's some companies, relationships are important. So we have investors who have been engaging these companies for years, right? So they want to maintain that relationship, but at the same time, they have to challenge that and challenge the people they're working with. So I want to make a more concerted effort to figure out how to connect there's public outcry around drug pricing. There's this organization that's working on this campaign. How does that then connect to what we're asking as investors? Because I think it just makes it that much more powerful. And then I think the companies are also, they're willing to listen because they hear the same message from the investors that they're hearing from the public or from policymakers.
Laura, would you like to comment on some of the challenges in your work? And some of the things that are on the mind, I think some people in the room, is that with many patient organizations, as you know, there is this financial conflict when it comes to pricing issues. Industry is patient organizations are doing great work, and they need funding from somewhere. Many of them take it from industry. When it comes to then working on drug pricing, that can create a challenge.
Yes, and as Peter says, I mean, that's one of our biggest challenges in terms of mobilizing is we have these huge organizations that essentially, that I won't name by name, but that essentially can do no wrong. And I think we even being patient advocates sometimes engage in this moral licensing on behalf of these companies. It's like they may do a camp, but if people are dying because they can't afford something as basic as insulin that's 100 years old, I mean, does anybody really need to be going to camp? But the biggest challenge is us getting our voices heard. We've been fairly successful with that on the state level, but on the federal level, just to give you a pretty easy example, as many of you know, I'm very active on Twitter, and I was giving the Surgeon General a hard time a few weeks ago for completely misrepresenting what diabetes is in general, but implying that it was caused by eating fast food. And so I started giving him a hard time. It kind of caught on, and he heard the message. He issued an apology via Twitter, deleted the tweet. But one of these big orgs saw all this happening, wasn't involved at all, but saw this happening, and then took that opportunity to get a meeting with the Surgeon General while you grassroots advocates were trying to do that, to presumably I mean, this is my pessimism speaking, but to presumably cut off anything that we were going to say ahead of time, because they are so aligned with pharma. So one of our biggest challenges is just getting people to recognize those conflicts and getting specifically federal legislators to recognize those conflicts and not to put so much credence in what these groups say and to listen to unaffiliated activists, grassroots activists, because we're patients and we live this and breathe this literally every single day of our lives. So that's definitely a huge challenge, and quite honestly, one that I've yet to come up with a good solution to.
Clifton, we're in entrenched state politics, working with and on behalf of marginalized communities in a challenging, sometimes moralistic environment. What do you do to overcome it?
Can I tell you a little bit about the challenge and then tell you what I do to overcome it?
Yeah.
Because I just need people in this room to hear that. Our biggest challenge, I think, in New York State especially, is genuine political will and the lack of it. What we are just inundated with are these pseudo-progressive politicians, these folks that claim to be champions on our issues and then don't show up, but claim to be champions so that we can't push them very hard. Because they're our champion, but then when we need them most, they're not there. So our biggest challenge in New York State, another big challenge, is that everybody outside of, well, maybe this might be my own perception because I'm from North Carolina, but everybody outside of New York State may view New York State as this progressive state, may view New York State as, oh, one of those great states that passed marriage equality, but doesn't know that within our borders we have people of trans experience are not protected under human rights law. They're murdered on a regular basis, discriminated against in jobs, education, housing, whatever they can be discriminated against in, it happens. Conversion therapy is still perfectly legal for minors, and 89,000 people are still homeless in our state, and we still have the largest percentage of billionaires on a block radius. So we're one of the richest states in the country, and New York City alone, if it was a state, would be the third richest state. So recognizing the amount of wealth that exists and the amount of disparity that is there, and then the amount of progressives that we have to meet with every day, I feel like my face is gonna fall off if I have to shake the hand of another fake ass progressive in our state. And I'm saying that coming from a place of love and radical acceptance. and I'm saying that recognizing that at this conference we've met a few politicians, but we need to make sure that we hold them accountable. I don't work on this national scale, but we need to make sure. So our biggest challenge right now is probably our governor, who is a Democrat. Who is a progressive and who has made a lot of great actually changes around HIV and recently hepatitis C, but not as a result of compassion and political will, but as a result of Cynthia Nixon. And as a result of us constantly being at his door, sleeping out on his front lawn and whatnot. So that is our biggest challenge to success, and it shouldn't be, because if they represent us, we shouldn't have to try so hard for them to do their jobs. But it is our biggest challenge, is political will. How do we, what was the second part? How do we
How do you
overcome it? How do we overcome it? We build power. We build coalitions with organizations with the exact same struggles. We kind of show light on the shadows that our politicians are really trying to cast in our state. And they try to, or many of them try to make some issues seem more paramount. Our LaGuardia is being built up, Penn Station is being built up, and there's still thousands of homeless people that are living in Penn Station on a daily basis. But our priority isn't housing those people, it's making Penn Station a little sexier for you all who kind of intersect on the Amtrak. So, so how do we overcome it is that we build that state power. We remind folks what a priority looks like, and what a priority should be for our state, what a priority should be for our politicians, and we get them the hell out of office. And we threaten them on again, love and acceptance. We politely disrupt their days, their dinners, their fundraisers, and we overcome it, and it also helps us thrive. It's our fertile ground because nothing feels better than pissing off the governor.
Dr. Powers.
I have nothing to say after that.
Maybe a somewhat different orientation than the hallowed halls of medicine. What is how do we get your colleagues to come around? What does it take?
So I think that the challenge here, and I don't know how many times we've already heard it this morning, right, is the narrative, right, of and how successful the pharmaceutical industry has been getting out this. It takes us this much to get return on our investment. And that's all a lot of people hear in the medical profession. And so either from their own willingness to rationalize or because that's all they hear, they buy into it, right? And is there a counter to that? So I thought it was very interesting when we published the study that we did showing the last 8 antibiotics, that 3 of them were actually worse for you, but they all cost way more money. We got a nasty letter signed by people from the pharmaceutical industry and the FDA together. A letter to the editor saying, you just don't understand drug development. Well, I've only been doing research for 30 years, and I just found out from that letter I'm an idiot. So that we don't understand that we have to get worse drugs, as an incentive for people, and that's going to get us better drugs in the future. Oh, pull the other one. Come on. So, plus, it's harming people today. It's unethical, right? I mean, harming people today because we're going to do better tomorrow. My kids try that with their homework all the time, right? I mean, I don't buy it from them. Why am I going to buy it from a pharmaceutical company, right? But what was interesting, we then just published an editorial or an analysis piece in the British Medical Journal where we outlined exactly why this is unethical, why the Declaration of Helsinki says when people with a life-threatening illness already have an effective option, you should not be designing a study to allow the new drug to be worse. You know what response we got? Crickets. So what I thought was interesting of that is they're just going to ignore us, right? So they're like, well, nobody's listening to you, so we don't have to respond to you. And I thought that was actually worse than the letter that called me an idiot, right? Because it says that we've got our narrative out there. We don't need to pay any mind to you, right? So I think that sort of is an action call to us to say we have to counter that narrative, right? And it was great to hear Senator Booker and Senator Smith get up here and hear 2 people who are in the halls of the Senate understand that that narrative is full of it, right? But how do we get that across to other people? As a part of the National Physicians Alliance, we went down when the last, the 21st Century Cures bill was passing, and I'm not going to say any names, but we sat with a very progressive politician in that person's office who assured us that they would take our concerns into account about what was written in the bill. Not one thing changed. And I thought that was really interesting. I mean, it's one thing to, be advocating out front with a sign. It's different to sit there face to face with somebody and have a conversation and then realize that they were just shining you on when they, and I thought exactly what Clifton said. Darned if I'm voting for that person the next time. I don't care how progressive they are on other things, right? And I think we need to be willing to do that, right? But I also put the other thing that I thought is the challenge I wrote down as being there. So like for me to take off from office hours or practice and go down and meet with people in Congress, that's a big deal for me, right, to get down there. And it's one of the reasons I joined MPA is that there's other like-minded physicians like that, and we can all band together to do those kinds of things. But, I'm sure lots of us have a day job, right? And so to be able to go do those kinds of things, they need to hear from us for sure to counter the narrative. But it's really important to be there, right? To actually take the time to do these things. And that's not easy.
Matt?
I don't know how to follow either of those things. So I'm going to be dorky. So here's one of the things that's really interesting, right? If you look at kind of history of policy change, right? That we can actually study this. We can actually think about what are the models of how policy changes. But we can also think about how policy doesn't change, right? And so one of the really interesting ideas, and from kind of political science right now, again, putting my like weird dorky academic hat on for a moment, right, is that there's this idea called policy monopolies and punctuated equilibrium, right? Blah 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 blah. But here's the core idea. How does industry, how does the current policy stasis stay the same way? Well, there's three ways, right? One, the idea of who gets to make rules is that we delegate these questions in Washington to a small set of folks who make the rules and make the agreements out of public view, right? That's one really core argument about, a really core way in which the policy stasis happens. Two, they create a really powerful idea. And this is true of pretty much every policy across the spectrum. They create a really powerful idea that justifies the continuation of the current policy, right? So if those two things are happening, one, what do we know? We know that the vast majority of questions around drug pricing are, as members of Congress actually got up and said, too complicated, you couldn't possibly understand them. They're taking place in these very, expert, ways. None of that is true, right? But it's a very powerful way because politicians, frankly, don't want to wade into something that's really complicated. That if they do this, they might affect that, right? They don't like to do that. And so they instead like to give it to the experts and let them do that. And then what's the really powerful idea? Well, we've talked about it a bunch, right? The really powerful idea is innovation, right? The current system delivers you wonder drugs. Hooray! Right? I was just having a conversation with somebody who is a vast expert, right, in this field, who said, look at the number of people who come to the United States to get these great new drugs, right? And I said, yeah, like there's like 8 really rich Europeans who fly to the United States to get these really rich drugs. Like, I'm not super worried about them, right? Like, that's fine. But like the reality of the many, many folks who don't have access, kind of both here in the United States, but also around the world, is reality. So how does then policy change happen? We have to address both of those things. One, the way in which stasis in policy across the way happens is that decisions get made out of the public eye, right? So if that is true, like the biggest thing we need to do is we need to make that no longer possible, right? And we need to insert new actors into the conversation. So, right, here's a few ideas. One, why are the mayors of the world, of the country, not actively involved in pushing back against these conversations because it matters for them? Why are the governors not, right? Why do we see so few of our kind of other elected officials being held accountable for drug pricing, right? I don't know, but it's deeply affected them. Why are so many of the hearings that are happening, right, totally happening with 0 people showing up and causing trouble, right? Why are so many of the FDA hearings happening where nobody is actually showing up there, right? These kinds of things are happening. How do we actually kind of bring that out? But then most importantly, how do you create a set of politicians who are actually going to stand up because they feel so much pressure, right, that they're going to inject themselves into the conversation? Because the way that industry ensures that actually these conversations don't happen is that they never involve the president. They never involve members of Congress. They have the conversations offline where nobody can see them. So if we can incentivize politicians where they have to deliver an answer to these things, they have to delve in, they have to go deep, they have to do what Senator Booker was talking about, right, and actually delve in and do that. If we can make half of the politicians engage, right, instead of 3% of the politicians engage, that can actually shift the debate. Second thing that they do, right, is they mobilize this incredibly powerful idea of innovation, right? So I know we've already kind of heard a bunch about this, but as we go forward, thinking about what are the frames that we can do to puncture that. If we think about the AIDS movement, one of the things that happened is that originally the debate was exactly this. The debate was, we are having innovation, you can't possibly disrupt the innovation. If you do, there will be no more innovation, right? But that was just not true. And we now have empirical evidence of this. Because you know what we did? We interrupted that system, and there's still massive innovation, right? This is happening. We know that that's true. What's the other frame that we could adopt? Well, the one that we have adopted often has been rights, right? So how do we think about the idea of rights? And you saw Senator Booker stand up here and say, healthcare is a right, healthcare is a right, healthcare is a right. Well, there's some ways in which that's, okay, cool, great. What do you actually mean by that? Not totally clear to me, but we'll talk about that another time. But this idea of using rights and demanding rights and mobilizing people behind rights can be at times a very powerful piece, because what does it do? One, it gets people riled up and excited. Two, it changes the conversation from innovation over here, right, to people's lives and what they have access to. And three, it brings together activists and lawyers and doctors in this really interesting way, right? So can we create a rights-based movement that actually is thinking about injecting that as the question? Because very few politicians want to stand up in front and say, we're actually not going to give you your rights, right? That doesn't happen. People don't stand up and say like, oh no, we've decided against giving you rights, right? Instead they say, well, there's innovation. So long as that's the conversation and so long as that's the frame that we're having it in, we're not gonna be able to win. So how do we shift it over here? And final point is just to say, again, not to belabor this point, but it is very, very, if we think about all those things, that's what industry is trying to do. They're trying to keep it off the table and they're trying to reframe it over here. They are not going to agree to have it on the table and frame it the way we want to. That's not gonna happen, right? So we have to create enough space and enough political power that actually those two things happen and those shifts happen. And until we do, we're not gonna see bargaining over things, right? We don't win in the end because we get everything we want. We win because we've opened so much space and there's so much demand and there's so much kind of angst out in the world, and then there's political space to happen, that actually when industry comes back in and says, no, you're wrong, the concessions that happen are on our side, right? So that we've demanded something bold, we've demanded something amazing, we've demanded the world we want to see, and then the bargain between the world we want to see and the world that industry wants is somewhere in between, not the world as it is right now and then a little bit better, because that lets them do a really good job of keeping it the world as it is.
I just wanted to follow up on something Matt said, and it gets to what I had said earlier about the narrative. We have to redefine this term innovation. It does not mean just something new. It means something new that is also better for patients on an outcome that actually matters to patients, not just a lab test, right, that people have access to and that they can afford, right? So what innovation means now is just something new. Right, I came up with something new and it costs a bundle, and I'm not really sure it helps people because it was approved by a regulatory agency based on a lab test. Oh, and by the way, that's going to be $18,000 a month for you. So I think if we can't get that term clear, when I actually, the other one that comes up, I didn't hear either the senator or anybody mention this today. I was actually asked to testify in front of Congress about this about 4 years ago, and I was admonished by, I said exactly those words I just said, and I was admonished by a representative from Illinois who said, you don't understand, the industry creates jobs and pays taxes. And that's another one I always hear. And I told my wife afterwards, I said, good thing it wasn't that movie Liar, Liar, where they can understand what you're saying in your brain, because I would have said yes. Creating jobs for undertakers is not exactly what we're in the business to do. So, because again, if we can't define these terms up front and get people to understand those, then we're going to talk at cross purposes.
So we've got a little more than 20 minutes. I thought I'd offer a couple of thoughts from public citizen and open it up for everyone in the room and others on the panel to talk with each other. You should feel free to push back on some of the points you've heard, because this is stuff that we have to hash out in order to build a successful social movement. Our sense is that this argument is outside of Washington. The argument about pharmaceutical prices is one. People don't actually believe what the industry says, generally speaking. If you look at the polls, there's tremendous demand for price reform, and the more serious the reform, the more people like it. They think that pharma is cheating them, and they want to take it back, take the power back, take their medicines back. We run into more problems in sort of the world of Washington lobbyists and expertise and groups and professional associations that are funded by that industry. But those things are responsive to power and mobilization, as has been said over and over again in this conference. So, our sense is that we need to mobilize, hence this conference, and that involves many aspects, right? Including improving the communication across all these different sectors that we're coming from, all the different ways we're seeking to influence these issues, have the advocates in different states talking to each other in networks, building our capacity to lobby together in Washington, and certainly increasing pressure on electeds all across the country through bird dogging, through generating many more calls to Congress and other kinds of creative activism and pressure. One of the problems that we see in that, in addition to just sort of the general resource challenges and logistics of getting us all talking to each other regularly and planning the next action, and we have thoughts about that, but is that there's an awful lot of diversionary tactic in this field, right? Where in addition to the canards of innovation and so on, you also have, I mean, if you look at the Trump administration's blueprint for reforming drug pricing, it's actually a strategy for how the pharmaceutical industry can survive this moment of extreme public outrage intact, with its business model intact. It shifts blame to other players, the pharmacy benefit managers and others, some of which certainly deserve their share of blame and need to be targeted as well. And it sort of dings the industry in one or two places, but just enough for them to sort of cry and complain and say that they're doing their part without fundamentally having to change anything. And then meanwhile, putting the bulk of the blame on other countries who have managed through a more assertive politics to pay ever so slightly less than we do here, which is perhaps one of the ugliest aspects of the proposal. It could cost an awful lot of people's lives, particularly in low and middle income countries, and we have to fight it in solidarity. So as we mobilize, we think part of what we have to do is focus on the reforms that matter and be super clear on the reforms that are going to work. Because if you ask any member of Congress at this point, they're getting the mail, they're getting the constituent mail, and they will have, many of them will have some kind of answer about what they're doing on drug prices. In some cases, it's deregulating FDA and making it an even weaker, more corporate-run institution. And they think that that'll bring down, or they claim that that'll bring down the prices of drugs. So we have to be in a position to say, that's not acceptable. These are the reforms that we expect. And so we and a number of the groups in the room, like Families USA and others, have been sort of working on process to figure out what are some of the reforms that we most want, and hopefully get as much discussion in the community as we can, so we can message and talk really clearly about that. You've heard a lot about Medicare Part D negotiation. You've heard a lot about stripping exclusivities. Our 10-word answer from Public Citizen anyway, of what we think needs to be done on drug prices that we'd like every politician to hear is increase our negotiating power, stop price spikes, and curb monopoly abuses. And there are a number of legislative proposals that fit under each of those. And those are acceptable solutions to the problem. And a lot of some of the other ideas that are out there aren't really going to get at it. So we sort of want to focus in on that, build agreement, and then work on how we collectively in this room build the movement and mobilize and apply pressure and bird dog and show up at the rallies to hold electeds' feet to the fire on those issues. And part of that is, as I was suggesting, is sort of how we communicate and continue this conversation. And we'll discuss that through the remainder of the conference. I think one thing I want to plug is that we are running an organizing table on the third Thursday of every month. So if you are welcome, everyone in this room is welcome to call in or show up and participate in a monthly conversation about building power and what tactics and rallies and legislative ideas and everything else you can think of we're pursuing to push for affordable medicines and coordinate and borrow the power of other organizations. So it's the third Thursday, usually in the afternoons around 3:30. So I guess the next one is, when's our next one? Well, in July. So that's what I have to say on that topic. And so now I'd just like to invite folks in the room or the panelists to speak up with other ideas, to ask questions, and push each other to get into the real concrete aspects of movement building and hashing out the things we've got to hash out to be successful, because to succeed, we're going to have to do it together. Okay, I see a lot of hands, so I think what I might do is take sort of several questions. What's that, Justin? What's that? Take like 2 to 3. 2 to 3, really? Don't we've got 15 minutes. What I'm thinking is, like take a round and then have folks answer the round, and then hopefully there'll be time for another round. All right, so let's get 1 and 2 and 3 and see where we're at. Here, let's get
we're
you
bringing
a
mics
mic.
out.
It's coming.
It's coming, okay. Is there another mic we can
Testing?
Okay, good.
Yep.
Let's get that to
Thanks. Dana Brown at the Democracy Collaborative, and I was just wondering for the panel and folks in the room, how you think that we can ensure that our movement for affordability and accessibility of medications goes beyond drug prices to some of the structural issues in our economy that are responsible for the fact that we get sick at such different rates and in such different ways. So that we get at the fact, I don't think it's very affordable for us as a society to allow whole swaths of people to get sick because they don't have good housing or they don't have jobs that allow them to afford food or to pay for baby formula. And so while, I know we need to ensure that we get certain regulations so that we can all afford to take our medication, I want to know how we ensure that this movement goes beyond that. So
Great
thanks.
question. Thank you.
Yeah, I'd like to hear a little bit more about the importance of educating as part of the work that we do. A couple of days ago, I was talking to my daughter about my coming down here and about my story of a medicine of mine being priced out. And she said, but if the medicine, does it matter that much if the price of the medicines go up? Because the insurance will pay for it, won't it? Now, this is a PhD tenured professor, okay? So we can't assume that just because people are smart, we don't need to educate them, because they may be smart about some things, but not about others.
Okay, we have a question over here.
It should be.
Okay. Thanks. This is a question about, I'm Vikas Sani from the Right Care Alliance. Thank you, Shannon. This is a question about how do we relate as a movement to politicians? I'd like everyone to think about that. It seems to me that, there's a phrase in diplomacy that, nations have interests, not friends. And I think we might want to think about that in relationship to our work. We have interests. And so I like what Clifton said, and I'd like to hear more. How do we structure our work practically so that politicians are accountable? Just a quick example, I'd love in a future conference to actually ask questions of some of the people who tell us that they're on our side.
Let's take one more question, and then we'll do the round. Let's go to the back, if we can.
Hi, Maurice from Acre. So several people mentioned sort of the spike in drug prices over the past 30 years. We heard about insulin and another drug. And I come from the world of studying and going after finance, so know that also happens to correspond with hedge funds and other financial institutions playing even more heavily into pharma. So I'm just curious if any of the panelists have looked at that and what the strategy would be to go after some of those companies that seem to be driving a lot of the price fluctuation.
All right, let's do one more after all. I want to get the ones again. We got Gail here in front. You can get up and speak real loud, I think.
My name's Gail DeVore. I am a citizen advocate, a patient advocate as well, but I'm also affiliated with a few different organizations. I sit on the boards of directors or I'm very involved with. Like Laura, I too am a type 1 diabetic by 46 years. One of the organizations, thank you, one of the organizations that I sit on the board of directors for, our tagline is, "We are not waiting." We have bypassed the FDA. I have built my own insulin pump. I have built my own remote monitoring system. It's available to all as open source. There's also an open insulin project where a PhD biochemist is developing his own insulin for open source availability to manage it on the open market and as a generic. We've bypassed FDA, and our government. How do you, can you guys address or maybe discuss a little bit about how do we continue along that line to be able to bypass what's preventing us from having affordable drugs and affordable treatment methods?
Okay, thank you. We've got 6 minutes, I've been informed. We're just going to go through the panel with the sort of rapid-fire open session. Obviously, we've got a lot to discuss, and I'm really looking forward to, I'm sure we're all looking forward to talking about these things with each other through the rest of the conference. So, who would like to begin? Okay, John?
So I want to address something Dana said there. And it gets to a question you asked me about how coming to this and being a physician. Medicine has now been translated into we're just pill pushers instead of taking care of the whole person and other things. At our NPA national meeting a couple of years ago, we actually had a person from the Harvard Divinity School who came and asked the question of why does the United States spend the most on health care than the next 10 economies combined, yet we're 39th in health care? Why? Because the other countries that have good health care have the infrastructure you talked about. So I think it is important that we make this bigger. We got to take bite-sized pieces. Right now, today, we're talking about drug pricing, but I wanted to reinforce that what you said is absolutely key. And it annoys me to no end when I'm treated as a physician like, well, what are you going to give the person? Instead of like talking about end-of-life issues or other things that come up regularly in the practice of medicine that seem to get bypassed for, just what pill are you going to give someone?
Meg?
So from the investor perspective, I had mentioned that we have these different sort of focus areas, right? And what we're trying to move towards, we have different groups that are having different conversations with different members or management and board of these companies. And what we're really trying to move towards is pushing them towards human rights and due diligence, right? So if we ask these corporations as investors to what are your human rights risks? Have you done an assessment? That actually opens it up to looking beyond just sort of access to medicines and drugs, but as a corporation, what are your risks and how are you contributing to human rights violations? So that's one way we're moving sort of out of this very siloed approach to something that's more holistic.
I love this question about, because I've been talking about politicians a lot, but I think one thing that we have to do, one thing that we've become very numb and used to is accepting people who run for office. If they can talk a good game, if they are attractive, which are other reasons why we elect them, if they're a man, if they're tall, if their teeth are straight, if they're orange. All of these things. And what we need to start doing is, and what we say a lot at Vocal, is that we celebrate good policy, not good politicians. And the moment that the rest of the country aligns with that message and that we celebrate good policy and we care about good policy and the people that bring that policy in is really just the messenger or the deliverer, but not necessarily the savior, because that's what they're elected to do, then we will prioritize and be able to kind of eliminate some of these behind closed doors type of things that happen because we accept politicians instead of and not really look at their actions sometimes, I feel like. And in that, I learned a really amazing word yesterday called intersectionality. And one thing that we have to do beyond the talking about pricing is that we have to talk about the intersectionality. And I know I'm not using the definition. I'm going against everything that the panel said today. But we have to talk about, for example, the Bronx, where for young people of color, children who are disproportionately impacted by asthma, who are disproportionately impacted by diabetes, who are disproportionately impacted by violence, police arrests, and poverty. It's not our jobs as advocates. For some reason, it's become our jobs. Or we've made it our job, but it's not our jobs as advocates, activists, organizers, community leaders to change that. It's our government's job to think about those intersections, to address those intersections, and to go beyond pricing of those of those medicines, and to think about how those medicines are actually driving some of those things. So I think to kind of put a bow on everything that I've really wanted to talk about up here is that we do not hold the government accountable enough. The government is the one that's giving out the patents. The government is the one that's that's regulating what kind of food is allowed in our grocery store. The government is allowing food deserts to exist in the Bronx. So it's the government that has to correct that. And the more that it's good to bypass the government when we really need something done, but that is not sustainable. That should not be a long-term goal. Our long-term goal is to make our government do what the hell they're supposed to do.
Thanks, Clifton. Laura, Matt, any fast final thoughts?
I think we've covered everything I wanted to talk about. I'd say one additional challenge to keep in mind, especially for the groups that lift up, individual advocates like Gail and myself and Hannah, is that in addition, and this is something Dr. Powers touched on earlier, in addition to having a full-time job that we essentially have to be able to afford our meds, we also have a full-time chronic illness that is so overwhelming I just can't even describe. It's kind of like playing a game of Tetris 24/7 all the time that you can never stop. And then we have our full-time advocacy. So I guess my ask would be for the organizations that already have the infrastructure set up, to lift us up as much as you can, to understand that we may not be able to give what you consider all just because of all of our competing, requirements. But I think this is a good start to get there.
Thank you. Matt?
So just a few quick thoughts. One is the question on education, right? And I think this is really interesting because one of the things that I think we often want to think about is the degree to which we need to move public opinion. We need to have public opinion on our side, et cetera, et cetera. I think there's actually very little evidence that that's actually what causes policy change, right? What's out there, and yes, education is really important and I totally agree. We should certainly not assume that professors know very much. But, right? This really central idea of thinking about the ways in which mobilized small groups of people can be wedges and the ways in which that can be disruptive is really important, right? So like thinking about the AIDS movement, one of the things that we know is that people living with HIV are not the majority in any country in the world. People living with HIV tend not to be the most prominent people in most of the world, and in fact are often queers and people of color and sex workers and young African women, right? And yet that has been a movement that's been able to change the price of drugs in really important ways, and for a couple of reasons. One, there's been very specific demands. So I think Peter's point and Public Citizens kind of checklist of what do we want? Are we clear on what those pieces are, and are they repeated often, and are they disruptive ideas? Right? That in fact, as we think about things like should all medicines be automatically compulsorily licensed, I think like these ideas that are disruptive that actually worry industry and actually building push toward them will create the space to actually move things in the right direction. And so I think kind of identifying that and then identifying ways in which there can be tight, organized, well facilitated groups that actually do the things that are needed. Somebody had asked earlier about kind of the stance to politicians. And I think one of the things that we just know is that politicians like to be loved and hate to be embarrassed. And so as we think about the incentives that politicians themselves have, there need to be strategies that actually are disruptive for their lives as well. Thank you.
Thanks, Matt. All right, we're 1 minute over, so we're going to have to shift into the next thing. If you're watching at home, let Big Pharma know that we're coming for them. Please thank our panel.